Okay, Dr. Sotero.
Today I am introducing Dr. Hannah Tully. It's a pleasure to just have her here to talk about her experience with fetal malformation counseling, which she is well prepared to do. But just as a brief introduction, she has a very interesting background, first studying visual arts at the Bennington College, getting a degree in fine art and music, and then becoming a painter. And then after that, she had, as she says, a chance encounter with a man who mistook his wife for a head from Oliver Sacks, and they lured her to do the field of neurology and eventually child neurology. She has been instrumental since she was hired by the Seattle Children's Hospital. I met her when she was a resident, and she raised through the ranks after getting an MPH and doing lots of research. A lot of her research has been in the area of malformation, posterior fossa malformation, a lot of it, and congenital hydrocephalus, and even alternating hemiplegia, as I found later. She right now follows babies that born from pregnancies that they call her to advise after ultrasound and fetal MRI shows some malformation. She gives advice to the families for that. And that's part of it that she is sharing with us today. And and she holds the rank of being assistant, soon to be associate professor in neurology, and she's now the program director for the pediatric neurology residency at Seattle Children's Hospital, the University of Washington. Without further ado, Dr. Tully.
Unmuting myself and sharing some slides. Did that come through okay?
Yes, that looks great.
Excellent. Okay. Thank you. And thank you for introducing me in my very kind of atypical path to get to where I am today, including this talk. But I do indeed have a background in art, which I am not doing much of these days other than photography, but that's going to be part of the theme of this talk. So let me give you a little context before we jump in. So this is going to be a talk about counseling for fetal malformations, which is done on the basis of MRI. MRIs, you're literally grabbing a moment or several moments in time. And for fetal counseling, as for other aspects of neurology, what you have to do is figure out what is slightly different about the MRI. Is what you're seeing typical, or is there something slightly different about it? If there is, does that even matter? So to kind of link this together through the presentation, we're going to be looking at pictures of what appear initially to be triplets, but may or may not be actual triplets. So these are old photographs. These are all historical photographs of children dressed alike, and they may be truly triplets, or they may just be siblings or friends dressed alike. And that's the analogy for looking at fetal MRIs and the counseling that we do based upon it. So let me try to advance slide. There it is. Okay. So because this is for CME, let me just kind of walk you through what we're going to be doing structurally. So we're going to be talking about fetal brain malformations or suspected brain malformations, 3 examples each of 3 different common malformations, cerebellar, ventriculomegaly, and a midline malformation. And in doing so, what I want you to be able to do is kind of live with me the difficulties of this field. Imaging is great. It's come a long way, but it's still inherently very limited. And I want to show you examples of those limitations. While recognizing those limitations, I also want you to identify things that you can probably trust as being clinically important, and be able to pick those up and learn what those mean for prognosis. And the other thing we'll do along the way is kind of, because this is inherently such an uncertain field, talk about how to work with that uncertainty in counseling. Okay, Figuring out how to advance, nothing to declare. My conflicts are all internal, and I won't bore you with those today. So this is based upon the work that I do with what has now rebranded itself from the Seattle Children's Prenatal Diagnosis Clinic to the Seattle Children's Fetal Care and Treatment Center. These are, I did a Google search on my own place of employment because that is hilarious to do. I urge you all to try that sometime. So when you Google Seattle Children's Fetal Care and Treatment Center, what you see is a sonographer working with a pediatric cardiologist, and I am not sure what they are pointing to. I do not know what body structure this is. But this is definitely the clinic that we work in. And here are two of our maternal fetal medicine docs who are bringing on board the interventional aspect of this program. Neurology, as many of you will recognize, is not inherently interventional. So much of my role and that of my colleague Dan Doherty is to scrutinize fetal MRIs, figure out what we're seeing, and counsel families about possible effects. So the way this usually works for families is the pregnant person is referred in at about 20 weeks. There's been an anatomy scan that has revealed a potential problem. So usually that means in another follow-up ultrasound. They're usually referred to an MFM, follow-up ultrasound a week later. And then when the problem is still there, then they get referred in for a fetal MRI, and there may be some delays there as well. So we're usually seeing patients at about 22, 23 weeks gestation in combination with the fetal MRI. And that, by the way, is always a scramble. Swedish has been doing some fetal MRIs, but it sounds as if you all are as booked up as we are, because there's increasing demand for them. We see, my colleague Dan Doherty and I see about 2 to 3 patients a week, and that is expanding. So 100 plus patients a year, with feels like more every week. And these visits are really a unique form of counseling, because I often start by asking what families need to hear, what they're looking for, and whether one of the key questions is whether this is a pregnancy that is going to continue no matter what, and they want information, or they're still deciding whether to continue this pregnancy. And almost always the answer is still deciding, want to continue, very much want to continue, but still deciding, and it will depend on what you tell me today. So these are hard visits. In a way, they're analogous to discussions had in the intensive care unit about goals of care. So to do that, the more information, the better. It's interesting though, just like in any form of counseling in neurology, the information has to be relevant to what families are, what's important to them. And it has to be as unbiased as we can possibly make it. The issue is that we all have biases, and it's really interesting. My colleague and I are very careful about giving the same information, but apparently we give it in very different ways, just our tone of voice, and parents hear very different things from us, even though I know that we've told them the same facts. So that's what makes these visits so challenging, as I still figure out how to advance these slides. So the idea of uncertainty is, it's going to be a theme for this talk, and I don't think I'm going to give a lot of clarity. I think it's you should have lingering uncertainty after this talk. I'm not going to ask for questions that I answer. So here are the issues. Here are the main sources of uncertainty. Artifact. So think about how hard it is sometimes to read an MRI when a patient has moved slightly. Blurs everything. It's really hard to see. Think then about trying to get an MRI through layers of a pregnant patient of a moving fetus. There's no way to tell that fetus to stop and hold your breath, right? The fetus is moving the whole time. Artifact in MRI is quite distinctive. MRI on someone who's moving their head in the scanner, everybody recognizes that. You see it as a specific type of artifact. With a fetus, it can look like anything. It creates distortion more than blur. So that's why I have this picture here, this blurred looking child. But it can be very hard to tell sometimes if what you're seeing is motion artifact or a true anatomic problem. So there's that. That's a big part of the uncertainty. The other part of the uncertainty is, even if we get the most perfect image where the fetus held perfectly still and we have beautiful cuts, we still don't always know the importance of what we're seeing or not seeing. So some findings, as I'll show you, are really easy to spot. You're not going to miss them, but they may not actually be prognostically very important at all. Whereas other findings that may be really, really clinically important, you may not reliably catch when the MRI is done. And it's still being worked out which are the important findings and which aren't. There's a whole lot of gray area in between. So even when, let's assume that we got a beautiful MRI study and we could really clearly say, yes, we see this thing, we see this issue. We still don't quite know what that means, other than we can name it, but we don't know what it means prognostically. And that's because a lot of the data, there just aren't large data sets for this. And a lot of the older data is coming from kids who were found to have these malformations. So there's acquisition bias there. Whereas cohort studies of malformations detected in fetuses, kind of on the basis of imaging, are really, really limited. Okay, yeah, so here, illustrating some uncertainty. Here's the luxury of a neonatal scan, where it was actually a baby who was quite still. We have a nice midline view. We have a nice axial T2 here. You can see a nice pituitary bright spot, normal structures. But a newborn brain isn't very myelinated, right? You've got a little bit of myelin here in the posterior limb of the internal capsule, but you don't have much myelin up here. And that makes it actually really tough to distinguish things like cortical dysplasia in a newborn, even with the most technically optimal MRI, just because it's kind of hard to tell at this age. That's why I always say, if you're still concerned, repeat an MRI in the future when myelin is more complete. So going back, this is also, I would love to see MRIs at this gestational age 30 weeks, because what I want you to see is, okay, smaller view, but this is technically a really nice one. And a lot of the structures are still there. We can see a complete corpus callosum. We can see a nicely shaped cerebellum. Brainstem structures look good. So you can still get quite good information. But the cortex is much less elaborate at this gestational age. So there's a lot that you just can't say about it. But this is 30 weeks. This is not when we're getting most of the MRIs. This one's a little earlier. This is 19 weeks, which is early for us. But basic structures you can see, and again, these examples I'm showing you are technically optimal MRIs, which don't happen that often. But here's a complete corpus callosum, great. Cerebellum, I suppose it looks okay, because it's on its own growth trajectory at this gestational age. They're small, so you can't really look at the anatomy too clearly, but it's there. So no obvious problems, but there's just so much that the brain hasn't done yet at this age. Cortex, look, we can see a cortex, but there are no gyri at this age. So who knows what could happen between 19 weeks and 40 weeks gestation. Okay, so let's walk through some practical examples of this. Cerebellar hypoplasia. The cerebellum is one of those underappreciated parts of the brain, I think, especially because it's so hard to see on an ultrasound. It's hard to see on a neonatal ultrasound through the fontanelle, but it's also hard to see on fetal ultrasound. So there are a lot of referrals for concerns for cerebellar issues. So here are 3 patients. These are all real patients. And they do seem to come sort of in weight. We get themes like this where we'll see one every week. So they are all in their early to mid 30s, and they are being referred in after an ultrasound with concern for a cerebellar problem. In one, the cerebellar problem was referred to specifically as asymmetry, which is unusual. Most of the time, they get referred in with Dandy Walker, because you can call anything a Dandy Walker if you want to. So Dandy Walkers is a common reason for referral, and it's usually not a true Dandy Walker that these end up being. So 3 patients, cerebellum, we'll figure out what it is after the MRI. Family history, one of them has a history of a cousin with a cerebellar stroke. Mom herself actually is homozygous for this mutation, and she's on enoxaparin and aspirin during this pregnancy. There has been no specific workup done. This was an IVF pregnancy, but otherwise not much else in family or her own pregnancy or previous medical history. Similarly with this one, this mom had gone through amniocentesis already and had a microarray done, and nothing was seen there. So let's look at our images. Okay, so we have 3 fetuses. They're of varying gestational ages, but what can we see? You always try to start with a mid-sagittal view. So here is one. Pretty nice view of the cerebellar vermis that actually looks fairly normal for 31 weeks, but this is the one that had been referred in with asymmetry. So we'll hold judgment on that right now. Here's one where they were calling it a Danny Walker, and you can see why. I mean, they were making that distinction on an ultrasound based on an axial view, but it's not far off the mark. Here we have a vermis that looks kind of small and possibly upwardly rotated, but the posterior fossa is not expanded. So our team over here would have lots of arguments about whether this is a Danny Walker or not. We would decide it wasn't. But the vermis isn't tiny, but it's suspicious over here. And here is, I'm not sure what I'm looking at. Here is a moving fetus where there were a few views of the cerebellum. And this is probably the best view. There's actually a view of the vermis, where the vermis looks a relatively normal shape, I guess, tucked against the brainstem, but it's really hard to judge that with certainty because it looks like the whole brainstem's missing, which it wasn't. But that is just showing you this is how bad it can get trying to get imaging on a moving fetus. Okay, but axials are the way to go. So here's our first fetus that was referred in for asymmetry, and sure enough, there's asymmetry, right? Y'all can see it. So we have a hemisphere. We have a hemisphere that looks normal for gestational age, and then it looks like something. To me, this looks like something took a bite out of it, right? Like it's just there's a chunk missing. It doesn't just look like it's small. It looks like it's sort of partially. It looks like an injury pattern, is what I'm getting at. Other things to see. There's a bit of dark signal right around it. Do you see that? So that's probably hemosiderin staining. So this is really, really typical appearance for this form of unilateral cerebellar hypoplasia, which we'll talk about. This one is similar, but not identical. The difference, so axial view, we got a good hemisphere over here, we got some vermis over here, technically not as optimal. But this side, this hemisphere, to my eye, just looks sort of small and shrunken. It doesn't quite have the same clastic look, like this was injured and then replaced by fluid. It looks like it just didn't grow right in the first place. It's really subtle, but it ends up being a really important distinction. Here is our moving fetus that looks maybe symmetric, but this is just not something you can trust. This was read as possible. Even the MRI was read as possible cerebellar hypoplasia, hemispheric hypoplasia, but it's so hard to tell. So these are the patients you have. These are the MRIs you have. What can you say reliably to these families? They always want to know why it happened, right? Why did this happen to the fetus? Is it something that I did? No, it's not. Cerebellar hypoplasia, hemispheric hypoplasia, not hypoplasia of the midline, the vermis. Hemispheric hypoplasia is postulated to have a vascular mechanism, which is a great hand waving way of saying we don't know, but it's not usually genetic that anybody can find. And again, this is limited to when it's so asymmetric. So sometimes you see hemosiderin, sometimes you can actually see a hemorrhage. Once in a while, you catch it and see diffusion restriction, but it probably is something vascular. The other thing to know about is face syndrome, which is named for this constellation of findings, which we'll talk about. But you can get a shrunken hemisphere, and you also get abnormal intracranial vessels with face syndrome. So it implies a connection, but it may not be that there was a vascular event. It may have been sort of a malformation of blood vessels that led to hypoplasia of the hemisphere. Then the next question is always, what does it mean, right? What does this mean for my child or for any child who has this? And unfortunately, what it means depends on what it is, and what it is not always so easy to tell in an MRI, but most likely outcome for unilateral hemispheric hypoplasia is really good. Those kids are remarkably not affected by it. Maybe subtle findings on exam. You'd certainly want to watch their development carefully, but it's quite amazing when it's diagnosed in the fetal period, how little effect it can have, as opposed to someone who has a cerebellar stroke during adulthood, right? So that's what outcome could be like. There's some limited data that says if the vermis is more part of the process, there will be more challenges, whereas purely the hemisphere, it's really can have minor clinical effects of that. And what are we gonna do? Genetic testing is often done, but it usually doesn't show you anything with this. So alloimmune thrombocytopenia is worth doing because there is this potential mechanism for hemorrhage. So testing mom's blood for antibodies is worth recommending, especially if there's hemosiderin or signs of a hemorrhage. But other than that, it's something that's usually just followed prenatally. After birth, babies get an MRI because of this association with face syndrome. They get vascular imaging as well. And we kind of take it from there. If there are other physical signs, face syndrome is its own specific thing. But sometimes a coagulopathy workup is something to consider. It's usually like any neonatal stroke or prenatal stroke, it's usually not revealing unless there's a family history. By the way, outcomes data, this is probably, it's a series of 26 and it's huge. In fetal literature, outcome literature, 26 patients is huge. That's a great study. So, but that's where this information is coming from about how these kids do, supplemented by the ones I see in clinic. All right, how do these babies do? So 2 of them, the families were already intent on continuing the pregnancy. That really wasn't something that they were more there for informational purposes. And both babies looked great at birth. They were vigorous, they were healthy. This baby had the earliest signs of a birthmark on the right side. Nothing raised at all. It was really, really subtle, a subtle flush, and also this tiny little soft tissue midline thing. But this is face syndrome. It's will become more recognizable when what is a hemangioma then becomes bulkier. It becomes really obvious, but that was the first sign in the neonatal period. This referral, this was a family who had a very, very low tolerance for any issue with the fetus, and they were already planning to terminate that pregnancy. This was the one without the artifact. So we actually got him a follow-up MRI to see if we could clarify whether there was a problem or if it was all artifact. But here are some follow-up MRIs. So these ones had postnatal MRIs. Here is the one which had the kind of chunk missing from the cerebellum. That's still what it looks like. A really nice hemisphere over here, and one that now is completely missing. Actually, if you go a little bit anterior, there was hemisphere there, but at this phase, yeah, it's gone. So this really seems like it was a classic injury pattern lesion. This other one where the hemisphere looked smaller rather than injured, you can see that it is smaller, like it has a really different appearance postnatally. Do you see all these swirling things? That is, that's dysplastic cerebellum. So what the mechanism of that is, because it's so focal, there's probably still some, vascular mechanism, but it's different from this baby over here. So this baby, this fetus had a follow-up MRI and luckily was still enough at the right time to be able to see a really nice normal looking fetal cerebellum. Perfectly symmetric. So this ended up being a non-issue. It was all artifact for that fetus. So how'd they do? Well, the one with the absent or large chunk of it missing cerebellar hemisphere is now 6. Doing great. She's eligible for the gifted program. She's an energetic child, but functioning very well at this age. So she's sort of going to see if she develops more signs of attentional issues, but she is, well within the spectrum of what you see in a kindergarten classroom. And I examined her so carefully because I thought I should be able to find something on her exam with, missing that much of her cerebellum, and it was incredibly subtle. When she would reach, she was off target a little bit, but it was subtle, which was amazing to me. I tried to get it in her leg too, just target pointing with her leg. I couldn't really pick it up in her leg. It was just that left arm. This baby with the dysplastic hemisphere. Playful, shy, just like her mom, but developing within the normal range, walking, running, multi-word phrases. Her issues, though, have been different because she has that dysplasia, and probably she has some brainstem involvement as well that have caused these major eye alignment problems. She compensates for it with the torticollis, but it's not affecting her cognition at all. So she's had a few surgeries to try to help with eye alignment. She had this hemangioma in her face blossomed from the subtlest flush after she was born to a big bulky lesion, propranolol, and a little laser to clear up what was left. And she had a little soft tissue lesion removed. And this baby, fetus was never heard from again, but pregnancy continued. So I'm taking that as good news. So let's recap this one. Unilateral cerebellar hypoplasia, again, not for the vermis, asymmetric hypoplasia. Still don't know what causes it, but we'll call it vascular because why not? And outcomes are usually good. But the major prognostic factors that you can identify on a fetal MRI is if you see these traces of hemorrhage or that kind of, sometimes you see a ghost hemisphere where you can see that there was a hemisphere there that then there was ischemia or something. You're probably not dealing with face syndrome when you see that. It probably was truly vascular. So that's an even better prognosis. Whereas if you have a dysplasia, it may be face syndrome. And then there may be these additional medical issues in the child. Here, by the way, is face syndrome. It's a bunch of white babies that you usually find on the internet. And even in a baby with very pale skin, it can be very subtle, the hemangioma in a newborn. But if you have a baby with slightly darker skin, you may not catch this at all until it starts bulking up. So there is a paucity of pictures of what hemangiomas look like in babies with darker skin, but that's probably because they're very hard to see initially. So don't let the fact that you can't see it make you think it's not there. So again, unilateral dysplasia rather than just an absent looking hemisphere. Hemangioma watch. And then when you see that, you may want to consider echocardiogram because those kids can also have heart issues as well, vascular differences. So that's why that's important. Moving on from the cerebellum to ventriculomegaly. You must have picked this because of these large bonnets. So again, almost triplets at first glance, but not in real life. So 3 more referrals to fetal clinic, 30s to 40s, and referred as they are at this time, as they are, usually around 20, 21, 22, 23 weeks with severe ventriculomegaly. Once it's severe, we can just call it hydrocephalus. But sometimes it's not clear whether it's truly progressive, which is what hydrocephalus implies. So when it's severe, it's usually picked up on these anatomy scans. Like the sonographer, the moms described that the sonographer was there, like did a few scans and then left the room to get the OB. That's usually the story. This mother here had an amazingly complicated history with lots of pregnancy losses. And so she had gotten an early anatomy scan. They'd first picked this up at 16 weeks. Other interesting things of note were this mom who was referred in, there were 2 maternal uncles with hydrocephalus. So immediately raising concern for X-linked hydrocephalus, usually L1 cam. Her workup though had been limited to, they'd just done a karyotype because that's I think all her insurance would cover. So they hadn't been able to test for L1 cam. Oh, and also it was a female fetus. Doesn't rule out L1 cam as a cause of hydrocephalus, but it makes you wonder a bit. Everything else was normal. This mom had pre-implantation genetic screening because it was an IVF pregnancy because of all these previous complications. That was unremarkable, but it doesn't test for hydrocephalus associated genes. This mom had SNP array, some viral PCRs from amnio, normal. Workup for these, by the way, is usually unrevealing. So what do we got? Midline sagittal is always the way to go with these if you can get one. Heads look a little large. We're in the midline, so it's hard to say much about the ventricles because there's a larger amount of fluid anyway between hemispheres, but corpus callosum in this, you can catch it, it looks really stretched. Concerning in this one is, and we'll come back to this, but posterior fossa not too big, but the vermis looks kind of small. And that brainstem does not look normal. It kind of angulates forward. So that ends up being really important to catch because it makes all the difference in terms of counseling. Bad hydro over here, but the brainstem doesn't have that kinked look to it. It's still, whenever hydrocephalus is bad, brainstem is displacing forward. So it can be hard to really clear it, but it doesn't have a kink the way that one does. Otherwise, it just looks like bad hydrocephalus. The vermis is usually small in hydrocephalus, whether it's a primary hypoplasia or whether there's some compression from fluid, hard to say. This one, sort of similar. Also, brainstem does not look kinked, but it's displaced forward. But you get a sense of this is bad hydrocephalus for all these kids. What it looks like on an axial, reaffirming that. Fetal brains at this age, not sulcated, so it would be hard to say much about that, but it does look sort of, it looks thinned even anteriorly and then really stretched back here. This pattern where one ventricle is much bigger than the other is absolutely typical, even when the obstruction's at the aqueduct, as it was for these kids. One side always just seems to stretch out more. Yes, sort of similar looks. Interestingly, almost all of the septum almost always goes away. It's usually here at this gestational age, but when hydrocephalus continues, often you don't see it on a follow-up scan. Coronals, yep, more of the same. So how are you going to counsel for this? They're being referred in. Why did it happen? It's so unsatisfying to have this conversation because we really don't know. And that becomes the answer. So there are always genetic possibilities, L1 CAM being the most famous, and then some autosomal recessive forms. But most of the time, you're not going to find a genetic cause. There was an interesting, tiny little study that looked at some severe hydrocephalus and found that there was blood inside the aqueduct and inflammatory response. So the implication was that there was a small volume germinal matrix hemorrhage or just hemorrhage from somewhere, because the germinal matrix is not even necessarily prone to hemorrhage at that early age, but causing scarring, inflammation and scarring down at the aqueduct. So that seems plausible, but they kind of converge on a similar imaging appearance, especially when it's the aqueduct that's blocked. So really it's all about, is there anything else that you see beyond hydrocephalus itself? What's the most likely outcome? Unfortunately, it sort of depends on cause, which we can't always tell, but even severe hydrocephalus, really severe hydrocephalus, it can be surprisingly not as bad as you think it might be. Let's put it that way. So these kids will universally have some motor delays, cognitive challenges. They may not have severe intellectual disability. It may be modest. They're at higher risk for ADHD, neurobehavioral issues. But it's surprising to see how these kids do long-term, let's put it that way. They usually can communicate and take care of some of their basic needs, even with severe hydrocephalus, except, because there's always an if, right? So if it's syndromic, it's a different situation altogether. So what do we do for it? Well, you know, a lot of patients are coming in already having gotten some testing. It may be a microarray, it may be non-invasive cell-free DNA, but I've actually never seen this show anything for hydrocephalus. More helpful can be. They now have a hydrocephalus panel, gene panel with some of the newer genes and some of the genes of which syndromes of which hydrocephalus can be a feature. That's usually low yield as well. Infectious studies are also low yield, but it doesn't mean they're not worth doing. Postnatal, well, imaging, neurosurgery, genetic testing. So let's talk about what happened with these pregnancies. So all these babies were born, all these pregnancies continued. This one was a twin gestation. And getting, you know, term or early term. And it's really interesting to these differences in outcomes. So, and what happened long term. So this baby shunted a day or two after birth and actually went home with a combo of PO and G feeds, pulled out her own NG tube pretty soon after, and has been exclusively oral fed ever since, and in fact loves food. This one, there was the unaffected twin. And so the family, it was really interesting. This family, even in the counseling session, had told me that they knew that their baby would die, that the affected baby would die. This woman had been having dreams about it. And so they took an approach of they elected not to get surgery and not to do any life prolonging measures. And the baby did die a few days later, and the twin was healthy. This baby over here, 37-week C-section, big head circumference, but vigorous, and kind of like this child 2A, got shunted quickly and went home on exclusively PO feeds before she was 2 weeks old. Let's look at some postnatal MRIs. This is hydrocephalus. I still kind of gasp when I see these. Here's our baby. What? It's similar to the fetal, but there's even more fluid. Baby 2, same thing. Baby 3, same thing. These are their neonatal scans. Here's the early shunt. There's some shunt artifact as well. But yeah, that's pretty severe hydrocephalus. This baby here, interestingly, has a little spot of heterotopia over there. Not sure it matters. So let's talk about how these children did, the ones that survived. So one child is 8. She is very lively and very healthy, but does not talk and does not walk. She does love to eat. She can sit with support. She has a combination of low and high tone. So she can sit with support. She loves to rock back and forth. She loves to slam things down on her tray table. She has quite a few seizures, probably more than her mother tells me about. And she has a Distroglycanopathy. This is muscle eye brain disease from an autosomal recessive mutation in this gene. So muscle eye brain disease in the spectrum of Walker-Warburg and other congenital muscular dystrophies. So she's somewhere at the not entirely severe end of the spectrum, but still pretty severe. And this child over here, also my patient, she's turned 3 recently. She was walking by age 2, and I've never seen this in hydrocephalus before, but she had very dysplastic to hypoplastic cochlear nerves. So she was profoundly deaf, and yet she had enough that was still residual that she got cochlear implants that she has used to great effect, and it's helped her communication a lot. She also, I don't know what this is, but she had lambdoid synostosis even before her shunt, and she had a quite impressive but secret Chiari malformation for her. She had a tonsil sticking all the way down her foramen magnum. So she got surgery for that as well. She has occasional focal onset seizures, but she is a lacosamide success story. Oxcarbazepine did not really help with these. Lacosamide made them go away. And just to show you their post-shunt scans, because it's so interesting to see the decompression. So both these kids, these are their most recent MRI, or not most recent, but more recent MRIs after decompression. Decompressed pretty nicely. Never, the back portion, it always stays, the white matter never comes back. You're always going to have ex-vacuole back here. But it's amazing how much re-expansion you got. The difference is this. So this child with her Distroglycanopathy has this cobblestone malformation. See it? Crazy wiggly gyri. And this unusual white matter. These are hallmarks of her condition that are so obvious on a postnatal scan. Not obvious at all on a fetal scan because the cortex hasn't built itself all the way yet. But what you can see, this is that kinked brainstem where the pons is just sort of big tectum, big midbrain, skimpy little pons, and that kind of retroflexion at the fourth ventricle. That's the hallmark of a Distroglycanopathy right there. So yeah, if you ever have a patient with severe hydrocephalus whose outcome is much more affected than you'd expect, like not talking, not walking, consider this, because sometimes this gets mixed. It gets blamed on hydrocephalus, but it's not that. This is more typical, even though she has these unusual, like she actually has some narrowing at her thalamus and her midbrain was a little narrow as well. But otherwise, her cortex is okay. And so that's why I think she has a very different outcome, talking and walking. So here's this patient. being fed by her brother. There she is with her hearing aid. She's now 3, but I just loved this picture. Just a gorgeous kid, very, very lively and attuned. It was amazing to see her after her cochlear implants too, because she wanted to talk to me. So hydrocephalus, probably a lot of things converge on this, but what you want to pick up is signs of an underlying syndrome, prominent massa intermedia, so these kind of midbrain findings that we wonder about, and the thalamic findings that probably cause obstruction, but they may not matter clinically, but that kinked brainstem, if you see it, that's a huge sign. An outcome, yeah, it's a hard one. Counseling can be kind of grim for these kids because the MRIs are so impressive and it looks like there's so little brain there, but it's kind of, for families who are up for waiting and watching and, you know, undergoing surgical intervention, it can be quite amazing how well they do. It's 2:01 midline. How are we doing for time? Oh, okay. Home stretch, sort of. Another group of pseudo triplets. 3 moms again. They're all 30. And they're all referred. So this is a common reason for a referral. When on an ultrasound, they cannot see the cavum septum. Cavum septum not so important in itself, but you can't see a corpus callosum on an ultrasound, so, or not easily. So if you don't see the cavum septum, it's really just a marker. So we get a lot of referrals for non-visualized CSP. Problem is, it can be just the angle sometimes makes it hard to see. Family history, who doesn't have several cousins with developmental issues these days? But sorry, I don't mean to be flippant, but there was not a really striking family history about this. And the workup, self-reading DNA, so non-invasive testing for fetal DNA in maternal blood, low risk for aneuploidy. They're never going to go further with this. It's a screening test. Like, they're never going to be more committal, but low risk, so not pushed to good amniocentesis in microarray during pregnancy. This mom here, non-visualized CSP, as is typical when they can't see it because it's so often due to fetal position rather than truly missing. Oh, she came back for a second ultrasound. They didn't see it on that one either. And then they wondered about the cerebellar vermis. Little information. She had undergone amniocentesis. This was normal. This mom over here, same thing, non-visualized CSP, went back and looked. Then they saw it. Then she got another ultrasound, but then they couldn't see it on the other ultrasound, which is a very typical thing. Find it, and then you don't, and then you find it, and then you don't. Otherwise, she hadn't undergone any genetic screening. She had a couple of healthy daughters, 3 healthy daughters who were fine. Here's what they look like. Sagittals are not the most informative view because you can't always catch a corpus callosum, but you certainly can't catch it in any of these fetuses. So, you know, you'd be wondering, you would want to correlate on other views, but not much to see there. Brainstem looks okay, cerebellum looks okay. Definitely not a corpus callosum that's visible here. Brainstem, cerebellum, maybe okay. This is where they were worried about the vermis. It's maybe a little small, but it's subtle. Here's our other fetus. Can't see a corpus callosum. Everything else roughly okay in this view. These are the informative views, axial and coronal, where there is not a corpus callosum for any of these fetuses. And this is a very typical, this is our more advanced gestational age fetus, very typical though, where medial hemispheres are kind of curling away from each other in the midline. So that's exactly what it looks like, curling away from each other, nothing across the middle. Sometimes you can catch a bit of anterior commissure across the middle, little teeny thing, but it's not, don't be fooled, because what you want to be seeing is the midline kind of curving towards the midline, these medial hemispheres, not away from it. Here's what to wonder about. So is this symmetric or not? So just like that first cerebellar series of kids with cerebellar issues, asymmetry is so important. So is this hemisphere, okay, we got a good looking cortex. What's happening over here? Is this artifact or is this truly a developmental issue with this hemisphere? Hard to say. In many views, that area looked just fine. but there were a couple of slices that looked suspicious for asymmetry. Asymmetry meaning possible dysplasia. This fetus, no, it is asymmetric, right? Like, but that's because it's an oblique slice. So we had a little more fissure over here, Sylvian fissure, a little bit less over here, just because of the slope. But if you correlate with coronal views and other axial views, it was symmetric. But that one raised some concern. Okay, so what are you going to tell me? Why did it happen? Why it happens has been the subject of many well-funded research studies that have not found major obvious associations. So like many other things in this world, it comes back to, I don't know why it happened, not sure. You know, it's well worth doing genetic screening testing, but usually what you're looking for is a major chromosomal anomaly. And then if there are other signs on exam that would suggest a specific single gene syndrome, you can look for those as well. Because it can be a feature of several syndromes, but several of those syndromes you can see without agenesis of the corpus callosum too. Most likely outcome. This is one of the hardest things to counsel for because on average, broad range of normal, you do not need a corpus callosum to have a normal outcome, as this meta-analysis shows. So about 3/4, this is when it's picked up in a fetal patient and there are not more anomalies identified. 3/4 of them are neuropsychiatric testing, development, hitting milestones on time, everything is in the normal range. You know, you're going to counsel conservatively, higher risk of needing educational support, some behavioral, interventions for if this is a child who is, volatile or has attentional issues. But really, 75% of kids are blending in with their fellow students. Only problem is there's still a chunk of them who are not in that category at all, who are severely disabled physically and cognitively. And how are you going to tell them apart on fetal imaging? So this is a hard thing to counsel for. Well, it's probably going to be completely fine, except there is a substantially elevated chance of having a baby that is not completely fine and could be dependent on you forever. So it's really tough. What do you do? Microarray from amniocentesis if the mom is up for that. If you can get exome sequencing covered, that's great too. Usually can't. After birth, because this affects midline, we kind of default to let's do an endocrine screen, MRI as well, midline, optic chiasm, optic nerves. So we'll look for that. That's usually not a problem with agenesis of the corpus callosum, but occasionally there's a weird, retinal coloboma or something. But there can also be chorioretinal lacunes, gaps in the nerve fiber cell layer that are basically pathognomonic for achardy. So you're never going to catch that without an eye exam, unfortunately, after birth. And then any genetic testing you haven't done for families who want that. Let's talk about these kids and how they did. So they are all born at term. This first baby was found in the neonatal period to be sort of surprisingly hyperreflexic. Babies without corpus callosums can be a little bit hyperreflexic, but it was a little sustained in this one, but still healthy, doing well, went home. This baby had a difficult birth, totally unrelated to the MRI findings. Just it was difficult, and there was a forceps extraction, skull fracture. But still did okay and went home within a few days. But unfortunately, at this follow-up, this eye exam was found to have chorioretinal lacunes. So achardy syndrome and intractable epilepsy are on their way. This child over here looked great at birth, uncomplicated delivery, went home, no issues there. Here are their postnatal MRIs. So they didn't look that different from each other, remember, on fetal, except for the concern for asymmetry in the middle one. Child is a little macrocephalic without a corpus callosum, but brain actually looks quite normal, and it does in other views as well. Cerebellum normal, brain stem normal. This child over here is suspicious because usually the gyri are coming down and forming an arch where the corpus callosum would be, but here there's this kind of odd thing that will correlate on the axials. This child over here, no corpus callosum. This is a more normal configuration. So these two look like isolated agenus of the corpus callosum. This one on sagittal raising concern for something not isolated. But on for some of them with follow-up MRIs, this child, there's not a lot to see. Like, it looks like isolated ACC. There's not major areas of dysplasia, nor are there on this child. It's a technically limited MRI, but nothing much to see. This child in the middle, here's her hematoma, but you can just see, even accounting for this, there's dysplasia here. There are unusual gyral patterns and asymmetries and a little cyst. So this is the one with the chorioretinal lacunes. So even before that eye exam, this had raised concern for something more complicated, including acardy. The eye exam is what unfortunately clinched that diagnosis. So how are they doing? Well, this child, when last seen in follow-up at age 4, is severely affected. He is not in that group of functioning in the broad range of normal. He has GMFCS level 5 cerebral palsy. He's been through a rhizotomy. He gets Botox. He's on baclofen. He does not have language, but he's happy and social. He likes to play with the dog. So despite the fact that his mom's non-invasive DNA testing showed low risk for aneuploidy, he turned out to have mosaic trisomy, which had corrected into a uniparental disomy, or partially corrected of chromosome 8, which we have a few of these. So his MRI is not distinctive, but it's this that is determining how he is doing clinically. And there were really I went back and looked at the images. There's not a lot of clues. No clues, I would say, on the fetal MRI that there was more going on. This child who did have clues to asymmetry and possible dysplasia has acardy syndrome, whatever that is. Genetic basis not clear. It's a clinical diagnosis, but she's very typical in that she's really developmentally impaired and has intractable epilepsy. Started with a combo of infantile spasms mixed in with some focal motor seizures and kind of didn't stop. So she's been through a lot of medicine. Family is now out of state, but yeah, they have had a rough go of that. And even though she was able to eat at birth, because of the seizures and the medicine, she couldn't sustain it. So she's partially G-tube fed now. This child over here is in that majority of 75% of kids who looks like anybody else. And in fact, his mom says, they never would have known that there's anything different, because he's, if anything, they say he was more precocious than his older sisters. And there he is. I'm showing you the happy pictures, but because I want to show you what's possible, but also recognizing what may not happen. So ACC, agenesis of the corpus callosum, we don't know what happens. Even though most of the time we can't find a cause, it is worth scrutinizing the MRI for acardy and doing genetic testing to look for chromosomal anomaly that may not have distinctive imaging features. So yeah, asymmetry is worth looking for, but asymmetries are sometimes artifact. So you can't really say confidently that it's an issue, but it raises your level of concern. So for these kids, yep, postnatal exam, optho exam, and labs. But for most kids like this one, who, or what happens most of the time, all of those tests are normal. All right, now I promise we're on the home stretch. So let's talk about this, because it's relevant. I don't want to make this a political talk at all, but it's really relevant to what's happening. Is when can we see things on MRI? So separate from even the issue of what do they mean, when can we even see them, right? So major malformations, sure, you'll pick those up at 20 weeks or at 22 weeks. But remember, major malformations include things like agenesis of the corpus callosum. Very easy to see, less easy to tell what it means. And it's so tricky because 75% of those kids are going to be like any other child, basically. But there are others with a much more severe outcome, and it may be tough to tell the difference. Cerebellum Affirmations, you can get most of these at a mid-gestation anatomy scan leading to an MRI, sure. But what I didn't get into, thank heavens, because it's long enough already, but there are a lot of things that you can see in a cerebellum that we don't know what they mean. So upwardly rotated vermis, see that a lot. It gets called a dandy walker, but then you check again and it's gone and you have a normal cerebellum, seems to be associated with normal outcome. So we can find things and we can name them, but we don't necessarily know what to tell families about what they mean. On mid-gestation anatomy scan or MRI cortical dysplasia, you cannot see reliably. Like, you may suspect it, and if you suspect it, say it, because it's important to have your threshold of concern raised, but it may not be real. And I sort of agonize over this one because there have been families where it's been suspected and, you know, we get a follow-up MRI and it looks fine. Everything looks fine. So we create a lot of worry for families when we do that. But if you really suspect it, if your gut feeling tells you it's probably, there's too much asymmetry for your liking and you can't blame it on an effect, have to mention it. Okay, so last, how so much uncertainty in this field, despite technological advances, despite accumulating data about how these kids do, there's still so much we don't know. You just have to be honest with families. So being concrete, families, it's really important. Some of them have a lot of experience with disability and some have zero. And, you know, they have an idea of disabled that encompasses all realms, but there's a big difference between intellectual disability or communication issues and physical disability. So kind of helping families to see those differences. I was just talking with my office mate about a patient of hers who has severe autism. He's not physically disabled at all, but it's a very hard life for his family. And you know this, that clinical trajectory is so important. Like, we'll give it a few more days. We'll see how the imaging evolves. Or in pediatric neurology, we'll see how your child develops, right? And cautioning families that what you see at birth, you have a healthy looking, vigorous baby, does not necessarily translate into a normally functioning older child. But at the same time, a baby who needs some extra feeding support may not need that long-term either. So trajectory tells you a lot after birth, but the trajectory can only really be defined by imaging before birth. So sometimes we overburden our system further by pushing for follow-up fetal MRIs, which are really, really helpful. Except when they're not, because sometimes you see new ambiguities. But a lot of times it can be helpful to get 2 points in time. Sometimes you can get that just by an ultrasound, but sometimes an MRI itself is helpful. Now we are done. So sources are here. I don't know if these slides are shareable somewhere. I'm happy to share them, but these are some helpful sources just about outcomes, and they're such tiny studies. That's it. Stopping talking. Text your attendance. Okay. Happy to take questions if there's anyone to ask them. Happy just to stop talking too. I will stop sharing. There are people in the audience. I couldn't see that. Did I see that there are?
Yeah, there's people in the audience. I have a question. Those numbers for agenesis of the corpus callosum, that is with the workup or without the workup, the 75%. So with doing
that is with the workup that was available. So it's not a standardized workup that they had. So that's the group of, we think that that's all there is that's going on. So automatically excluded are ones, you know, who later turned out to have major malformations. But these are the apparently isolated, and it's a moving target because when that study was done, it itself, based on older studies where imaging wasn't as good. So I think if we did that study again today and we limited it to truly isolated agenesis of the corpus callosum, it'd actually be even a higher proportion functioning in the normal range. That's what matches my clinical experience.
I'll give a minute, see if somebody else has another question.
Yeah.
I have another quick question for you, if nobody has a question. Okay, I'll ask you. So, oh, maybe somebody has a question? No.
Yeah.
Oh, yeah. somebody had a question. The first baby,
With the
mom
mom.
had
Yep.
MTHFR mutation, or mom and perhaps later the baby methylfolate and B. Well,
It's a great question. I don't think they
on.
were. I remember them being on enoxaparin. The mom was on enoxaparin and aspirin because they were worried about clotting risk, especially with the cousin with the stroke. And in fact, it makes you wonder if that wasn't a stroke, but actually a bleed from what she was on. I don't know that. But yeah, I don't know about those. I know that I do see babies on them now and moms on them now, but I don't remember them being on that.
Another big thing that has been for me very challenging is all the babies that get the diagnosis of fetal ventriculomegaly. How many of them have hydrocephalus, and how many of them end up having a malformation?
Yeah, and I'm biased because we don't tend to get the mild referred into us. So of the actual, like if it's 10 or 11 millimeters, that's kind of nothing. I think when it gets to a certain degree of enlargement, it's usually, you can call it hydrocephalus confidently, and it's usually obstructive. Sometimes it's an ex vacuo or a malformation. But if it's for asymmetries, like there have been a couple where there have been a referral for unilateral ventriculomegaly, and you can see it's actually hemimegalencephaly. And I worry that that wouldn't be picked up, on a 20-week scan, but it's more obvious later in gestation. But
And
yeah, that's kind of a mess of a area because there's so many different things.
and this number that you get, the millimeters, is the biparietal, the anterior measurement, the same one that you use to follow up on the MRIs, right? And the hydrocephalus.
No, it's not, because what they're measuring for fetal ventriculomegaly is occipital horn width, and there's all different ways that people are doing it of the ventricles themselves. So all through a pregnancy, 10 is your cutoff, and sometimes like spinal tap, you can go to 11. But male fetuses, interestingly, tend to be slightly bigger, but 10's the cutoff at any gestational age. They're simultaneously measuring head circumference and biparietal diameter. It doesn't, as soon as you get born, they stop quantifying it that way. So for premature babies, they'll be quantifying frontal occipital horn ratios for like post-hemorrhagic hydrocephalus. And then they sort of stop measuring after a while and just look at qualitatively what the
Got it.
look like.
There's one more question there on the about
imaging MRI with pregnant women with epilepsy. But yeah, my bias, despite my loving to look at MRIs, is keep it simple, because the more tests you do, the more you'll find, and you won't know what to do with the answers. I think it's always good to start with an ultrasound, recognizing what an ultrasound can't pick up. Ultrasound isn't great at cortex. Ultrasound is also not good at cerebellum, but it's usually enough to identify a problem back there, but not enough to tell you what the problem is. But it seems like a reasonable place to start. But then again, it also becomes a question with the family. There are some who are quite content to say, we'll do an ultrasound, that looks okay, I'm not going to worry about it. And some who cannot sleep until they get an MRI. So I think that's part of the decision too. Yeah, but ultrasound will be limited. It's also not going to pick up a brainstem malformation, but it could tell you something about the orientation of the cerebellum that would raise suspicion.
Great, man. This was an outrageous talk. Thanks a lot. This is like almost years of experience in a can or whatever in a pill. I really loved it. It's great. Fetal neurology and counseling is a great area that you're developing. I'm happy we have somebody as smart as you at Children's doing that, because we do like that.
I am supported by my very smart colleague.
Yeah, you and you paired up with Dr. Doherty, who's the other
he's
great
amazing.
guy.
And our radiologist too. You have great radiologists as well. But yeah, I mean, it's nice to be able to talk.
Anyway, we have passed a little bit the hour, and people have clinics. So Thank you very much for the talk.
Thank you. Thank you for the opportunity. It was a
No, it
pleasure.
was great. Thanks a lot. Appreciate
Okay,
it.
thanks. I will see you later on. Bye.
So see you later. Thanks.
Thank you.